Good afternoon, everyone. This session is an advanced practice session, and it's entitled Advanced Practice Providers on the Frontline of Diagnosis and Treatment. These are disclosures for the three of us. And this session is co-sponsored by the Association of Neurovascular Clinicians. And today we're going to discuss unique roles by the advanced practice providers. All of the roles discussed today are presented by board-certified advanced practice neurovascular practitioners, or ANVPs. And the ANVP is the only neurovascular certification for advanced practice providers that's available. ANVPs have completed a fellowship training and have received education and competency regarding clinical localization, imaging interpretation, pathogenic mechanism, and also inclusion-exclusion criteria and TPA administration. They also possess a strong background in acute disease management. If you, many of you already are interested in the ANVP certification or any of the other certifications that's provided by the ANVC, please visit our website at anvc.org. So the first unique role that we're going to talk about today is mobile stroke units, taking stroke care to the streets. MSUs are increasing in presence across the world, with most of those being available in the United States. MSUs allow for rapid assessment. There's advanced imaging possible. Most of those use manual injector CTAs so that they can visualize the circle of Willis. However, our CTA at the University of Tennessee in Memphis has an auto-injector allowing us an arch neck and head imaging. It also provides for ultra-fast treatment, transport to the most appropriate facility, and this is the one thing that we're really proud of. Because of our imaging capabilities, we have not ever had the experience of taking the wrong patient to the wrong type of stroke facility. Most all mobile stroke units use telemedicine with a nurse on board. The issue with this is that they cannot do any independent ordering and have to rely on either telemedicine or remote, some kind of remote contact with their MD or another nurse practitioner. Some use vascular neurologists on board, but this is pretty expensive. Our team in Memphis consists of an advanced EMT, which also functions as our driver. We have a paramedic on board, a CT tech to run the CT, and then also an advanced practice provider that's ANVC board certified. So what is the mobile stroke nurse practitioner responsibilities look like? Our mobile stroke unit, we make a definitive diagnosis of stroke. So one of the lessons that I think we've all learned is not only how to diagnose stroke appropriately, but also how to sort out what is not stroke, which sometimes is the bigger job. We do engage in other neurologic or vascular emergencies. So for instance, if we came upon somebody who was having hypertensive crisis or hypertensive urgency, we would likely transport those patients because we have carding on board and the regular EMS service ambulances do not. If it's likely stroke, we can localize findings to vascular territory and review the imaging. We can determine the treatment plan, order blood pressure control, order alteplase, notify the vascular neurologist of the diagnosis and the treatment, and then if there's further intervention that needs to happen, they help to mobilize those teams for us while we transport the patient. We also can manage other concurrent medical problems during transport. We have noticed that nurse practitioners are being utilized in other models for mobile stroke units around the world. Some of these situations, though, have posed themselves that the nurse is on board, really support of delivery of care that's ordered by a physician. And the one thing that we feel is really important, especially, and we've tried to live out in our model, is that we want to practice to the best and the fullest capability that we have. The second role I wanted to talk to you guys about is telemedicine. And when I think of telemedicine or telestroke treatment, I often think of the acute emergency room, alteplase decision-making, capabilities. And we do have some of our ANVPs that are actually in that role and kind of leading that charge in the emergent diagnosis. It also is helpful for triaging to higher level of care, making sure that we get those patients at the outside facilities to the right place. How we've utilized telestroke services at our institution, utilizing nurse practitioners, is by developing an inpatient consulting service for our outside hospitals. And so this allows for hospitals to keep these non-complex stroke cases. Some of them receive TPA, some of them are subacute strokes, but anyway, it allows them to stay in the outside hospital if it's safe for them to stay there. It allows the patient to stay in their own community hospital or the hospital that they presented in. And I'll tell you, as far as satisfaction goes, the patients and their families are so happy with this because it is very stressful for many of them to think about traveling downtown in the city. So this has been a real benefit for these patients. It increases the volume at our primary stroke center and our acute stroke ready stroke centers. And maybe one of the most important things is that it has helped to decrease some of the volume at our comprehensive center, which I think probably most of you that work in a comprehensive center know how precious those beds are. One of the other things and reasons for implementation is the savings of the healthcare dollars. So whether it's the patient or the hospital system that the savings occurs in, this can be really significant. So if you have a patient in our area that needs to be transported by ground, probably the minimum charge is going to be about $2,000. If they're flown, it may be $12,000 or $15,000. So if you can save transport of 1 or 2 patients a week, you have significantly reduced the overall healthcare dollars spent. Next, Ann Alexandrov is going to present on emergency departments.
So in case you didn't notice, I'm not Jennifer Patterson. And in fact, Jennifer's dad just had a bad heart attack and got rushed into emergency open heart surgery. So he's apparently doing really well. Talked to her this morning, got extubated last night, but she won't be out here until probably Saturday morning. So everyone keep her dad in your prayers. But this is me, Ann Alexandrov, and I work at the University of Tennessee Health Science Center with my husband, who is the chairman of neurology and the director of the vascular neurology program, which is a citywide program. And I'm also the chief nurse practitioner for our mobile stroke unit. So when you think about what you can do in an emergency department nowadays when it comes to stroke, it all really comes down to decision making, right? And making decisions pretty darn fast. How many of you work in an academic center with residents? Okay, so what's it like in July when those residents starts and you have a PGY2 in your emergency department trying to make a decision about whether you should treat an acute stroke patient? It's chaos, right? And this is where you really kind of need what I like to call the attending nurse role, someone who's been there, done this so many times that PGY2, and sometimes it's a weak PGY3 that's on as well, that can really kind of lean on you and help you, just kind of help them guide through the process. Because otherwise we tend to see that the door to needle times go way long, decisions are not being communicated to the attending physician or the interventional team in a timely manner, and it just, the whole process kind of falls apart. And because nowadays we try to make those decisions so fast, I really think that taking an advanced neurovascular practitioner, an A&V board certified nurse, and putting her down, or PA, down in the emergency department really can make a huge difference. Now, what I want to share with you, and this is a picture of Jennifer's emergency department, because I kind of slapped some ideas on top of her slides to make it my own when I heard last night that she wasn't going to be able to make it. But this is her emergency department. She's at Erlanger in Chattanooga. So I don't have pictures of mine, but What I want you to kind of think about is, can you establish kind of a dedicated unit within an emergency department, right? And that's what we've done at the Methodist University Hospital in Memphis, Tennessee. So what we've got is we've got a system that ensures that diagnosis and treatment, especially in an academic program, is covered by a group of expert nurses who are specialty trained and educated and credentials, and they do not rotate to other parts of the emergency department. They stay exclusively in this area that just takes vascular emergencies. So they kind of resident-proof the facility, if you will. Many of them have also gone on and become dual trained in getting the cath lab up and operational, especially if it's in the middle of the night or if it's on a holiday or a weekend and there's not a team in-house for whatever reason. The team's usually pretty close, but you know, the bottom line is it's nice to have someone kind of start getting things going before the team gets there. And then the other thing that they've been trained to do is to oversee brain attack teams at all these referring centers that send cases into us. As Wendy told you, now we're in a situation because of Wendy's leadership where we can keep people out there at some of these smaller hospitals if they're small vessel occlusions, and we don't have to bring them in just because we've given them TPA. But these guys have them so well trained, and my husband with his system has kind of gone in and made sure that all those emergency physicians know that if a case comes in, you don't stop and make the decision yourself. You call the brain attack team center in our emergency department, and then those nurses get everything going, including whoever the vascular neurologist is on call. And I really have to credit Lucas Elahovich for all of this, who's coordinating our meeting this year at SVIN, because he's the one that really built this very, very unique system. When we were Joint Commission certified, they were in love with it. I think Karen was our reviewer. And then now we're DNV certified, and they absolutely love it too. So it is just an amazing system. Now, what about thinking about pre-hospital providers and what it is that pre-hospital providers do that an emergency nurse practitioner expert can really kind of oversee? Well, I think, you know, step one, you have to be very savvy about what protocols are in your state for EMS because everyone operates very differently. And Jennifer was going to tell you a little bit about her work. She's my PhD student at UT Health Science Center, and she's actually very interested in health policy, and in particular, this kind of whole pre-hospital piece that is tied to door in, door out. And so she started to kind of unravel some of the stuff that's going on out there. And it's interesting how you see, as she puts it, that people put up policies because they think it's the right thing to do to protect patients, but sometimes it ends up hurting the patient. For example, aspirin 81 milligrams by mouth in the field for symptoms of a stroke. Is that crazy? I can tell you, my husband and I, when we first came to the state of Alabama years ago in 2007, found that Joe Acker in the state of Alabama had written policy for EMS that you always gave a baby aspirin by mouth in the field. You know, so kind of generalizing a STEMI approach into a stroke approach, and of course aspiration pneumonia, including pneumonitis. If you suck an aspirin down your lungs is not a good thing, right? So we had to work very hard to change that. Some of the things that Jen has found more recently is that in some states, like the state of New Jersey, I don't know if anyone's here from New Jersey, but in New Jersey, if you've started the patient on either TPA or an antihypertensive infusion, you cannot let that patient out of that primary stroke center unless you have a critical care ambulance, and they only have a handful of them in the entire state, and you take one of your nurses out of practice and put him or her on board, which a lot of places can't afford the staffing to do that. So their door in, door out times are phenomenally long, and yet the state thought that they were protecting patients doing this, right? So very kind of naive assumption as to what would happen. And then you go and you look at like Australia. So they've got some real crazy things going on down there. They have a no lift policy. If you are working in the field as a paramedic and you're responding to an acute stroke, which commonly has motor dysfunction and is unable to walk, you are not allowed to lift the patient onto a stretcher. You're not allowed to lift the patient out of the apartment. And if you're in a big city like Melbourne, Australia, where their mobile stroke unit is, instead you have to wait till they show up with a second unit that has a special lift device that has to be brought up to the patient, and then that is used to lift the patient because, God forbid, we should hurt the backs of anyone working EMS, right? So again, policy created to help the provider stay safe, but their times on scene are incredibly long because of this requirement. So Jennifer's become very interested in this and is really doing a significant amount of work on it. And then the last thing I just want to mention real quickly is that research in the emergency department really requires expert advanced practice provider oversight, someone that is part of that IRB approval, that can do early consent, early randomization, screening, the whole thing, monitoring of the patient once an intervention's been provided. And it is important to remember that emergency department staff are notorious for not following through with any additional work whatsoever. Their hands are full. Do not expect it. I spoke on this for Ed Yauk about 4 years ago at the ISC in the emergency center, and people were saying, but they won't enroll subjects in my trial. Well, guess what? If you can't be there, pay someone to be there to enroll your subjects. Because if you don't, no one's going to get enrolled. And that's just the way that it is. And then the other thing is that few sites are capable of doing ED-based research well because they lack someone that is there 24/7 to make this happen. And it's got to be seamless. It cannot slow down processes. So if you're doing something in the ED, make sure it's pragmatic, it fits within standard of care, that you're not slowing down time to TPA, that you're not slowing down time to the cath lab. And this is how we've designed our Zodiac trial, of which I'm the PI. And if you have an interest in participating because you work as an advanced practice provider in the ED, please talk to me. We are looking for more sites and we'd love to have you on board. And I will thank you so much and turn it over to Natalie.
All right, we're going to shift gears in two different ways. So we are moving from the acute management, hyperacute management, to the outpatient setting, and from primarily vascular neurology to cerebrovascular neurosurgery. So my name is Natalie Hall, and I'm a nurse practitioner that primarily works at Vanderbilt University Medical Center in the cerebrovascular neurosurgery clinic. I also work with the brain tumor team at Vanderbilt and on the mobile stroke unit in Memphis, but this is my primary role. So there are a lot of different practice models that are successful, and some maybe more so than others, for advanced practice providers working alongside physicians, both in surgical fields and non-surgical fields. This is our structure at Vanderbilt that's been successful for us. So our inpatient team is comprised of 2 nurse practitioners that only work in the hospital. And then our outpatient team, I'm the nurse practitioner that only works in the clinic. And our 3 neurosurgery physicians that are cerebrovascular specific obviously work in both settings. So our inpatient team is responsible for managing the acutely ill patients who are on service, managing things like EVDs, pre and post-op, assisting in the angio suite and cath lab like Ann mentioned, and enrolling our patients in our acute research studies that we have going on. In the outpatient setting, I split time with the tumor team but see patients in our clinic 2 days a week and manage all of the outpatient follow-up needs for all of our cerebrovascular neurosurgery patients. So that includes stroke-related diagnoses like post-stroke thrombectomy or post-thrombectomy stroke patients, carotid artery stenosis, intracranial athero, moya, ICH, aneurysm with or without rupture, And a lot of these are managed both medically and may have some surgical or procedural component. So there is, these patients are managed both by nurse practitioners in the hospital and outside the hospital. We all practice to the fullest extent of our scope of practice, which is really important, but also work parallel to our physicians, allowing for seamless transfer of patients between the NP and the physician. So in the outpatient clinic, there are the post-op patients, whether they are coming in because they were just released from the hospital after an acute unplanned event, or they had an elective procedure. They are returning to the clinic the majority of the time with some kind of post-op imaging. Managing any kind of comorbidities that may have contributed to their condition, managing any complications and preventing complications, trying to keep the patient in their home or the outpatient setting, preventing ER visits and readmissions is really important. And I'm able to do that because I'm physically present in the clinic 5 days a week. I'm there to answer patient questions almost immediately when they come in, rather than waiting for a physician who has a clinic day once a week to answer the question. And in the meantime, the patient gets so concerned or may have an actual, acute problem and end up back in the emergency room or readmitted. And then there are the patients who we are following long-term, who may be post-op and or may not be having any kind of procedure that we're managing long-term medically. So the physicians and I manage these patients parallel, but again allow for seamless transfer between the NP and the physician. So for example, a patient with asymptomatic carotid artery stenosis that's being managed medically, even though they're being managed medically and all of their comorbidities are optimized, they may still have progressive disease and or begin to have ischemic events and become symptomatic. In that case, the patient would then need to be routed back into the physician's practice to discuss intervention. So running independent but parallel practices and having open communication and good support by the physician allows for that seamless transfer of the patient. So at Vanderbilt in our clinic, I see approximately 40% of our entire clinic volume for cerebrovascular neurosurgery. The 3 physicians combined see about 60%. Because I'm there to see a lot of our patients, almost all of them are return or post-ops. Now, nurse practitioners, PAs, are entirely qualified to see our new patients, but this is our practice model at Vanderbilt, and it's been successful for a few different reasons. Our physicians are then able to see more new patients, some of which are surgical, and therefore, in turn, increase surgical volume, which they are very excited about. So it has been successful by our physicians seeing the new patients first, primarily because our patient population tends to be a little bit nervous and hesitant going to see a surgical specialist, but seeing an advanced practice provider and not a surgeon. So by seeing the physician first, our physicians are really great at presenting our practice as a team to the patient. They set the expectation up front with the patients that they will be seeing APPs both in the hospital and in the clinic as part of their care. They set a clear understanding with the patient about our roles and show their verbal support of the APPs, which really helps out with patients trusting the APPs going forward, and it really mitigates that patient pushback on seeing an APP in the surgical field especially. So APPs can enhance physician practices in a lot of ways, but specifically to cerebrovascular neurosurgery, increasing the overall patient volume in our clinic by having another billable provider there every day, improving access to care for patients. Patients don't have to wait till the next clinic visit or the next open spot in a busy surgeon's schedule if they have a problem or a concern they have. And for our new patients, it really opens up the physician's availability to see more new patients, get them in quicker. A lot of our patients, they have a new diagnosis of an aneurysm, and patients hear the word aneurysm and immediately are convinced they're going to die in 2 seconds. So being able to get them in to see our physicians quickly and not have to wait a month before they can be seen is really helpful in keeping patient satisfaction high and also keeping our referring sources happy. So I mentioned that improving access to the physician seeing new patients also indirectly increases the surgical volume which the physicians are happy about, as are hospital leadership partners. So having an APP in the clinic to answer all the questions for these patients and manage the outpatient needs essentially eliminates the burden of cross coverage, at least in the outpatient world, for our physicians when one is out of town. Again, that's a huge perk for them not to have to worry about covering not only their partner's acute patients, but also the questions that may not be any urgency, but the patients continue to call about while that physician's out of town. So efficient response to patient questions and calls, improved communication with other providers about mutual patients, all of those things increase patient satisfaction as well. Having a nurse practitioner or PA in the outpatient setting also helps with continuity of care between inpatient and outpatient to make sure all of their outpatient needs are met, whether that's therapy, referrals to other specialists, medications, follow-up is arranged, and working with our research studies for the long-term follow-up visits and making sure that we are keeping our enrolled patients on timeline and reducing deviations to protocols. So in order for this to all work out smoothly, several things are needed. The advanced practice provider has to be cerebrovascular trained, and that's beyond the NPPA basic training. Someone cannot walk into this role and be successful without having formal postgraduate education in the cerebrovascular world. And part of that is strong interpretation of imaging skills. That doesn't come overnight, and that's something that, in my experience at least, is not really taught in P school anyway to a great extent, and the extent of detail that you need to independently practice and review this imaging with patients. The majority of our patients are coming from to see us directly from an outpatient imaging study. So that means that they arrive in our clinic 20 minutes after they've just gotten off the MRI table. 9 times out of 10, the radiology report is not available to review, so I'm responsible for reviewing those images independently, asking questions when I need to, but also being able to review those images with the patient and their family. So that's not only knowing what to look for, the expected findings, but also being able to analyze the imaging for anything unexpected and being able to relay that information appropriately and accurately to the patient at that time and not waiting hours for the radiology report. You have to be proactive and know what you don't know and know when you don't know it. That does mean going back and following up on the reports to make sure that you didn't miss anything. That means if something comes up that you don't know, not assuming that you do know it, and just being willing to be humble and ask questions when you need to, and that facilitates lifelong learning in your career as well. You're also representing the physician and the practice, and you have to do that professionally, and that's especially important with communicating to referring providers and other providers that are seeing these mutual patients. Aside from a well-trained APP, you also need to have a good relationship with the physician that you're working with, which requires active participation on the APP's side as well as the physician's role. There needs to be a clear expectation and a clear understanding of the scope of practice and the APP's role. The goal, as all of us APPs have, is to work to the full extent of our practice and scope of practice. So having that clear expectation and understanding of each other's roles and scope of practice up front is invaluable. Having a shared philosophy of care, everyone being on the same page as far as the evidence-based practice that you are providing together, being aware and respectful of the physician preferences, and following through with those on their patients. I'm managing patients for 3 different physicians. Now, all of them are practicing within, evidence-supported guidelines, but there's wiggle room, and some physicians prefer one thing, the others prefer another thing. So respecting and knowing those preferences is really important to build rapport with your physicians. Open communication and mutual respect and trust is also invaluable. So none of this happens overnight, but over time, being able to build a successful relationship with the physician where there's open communication, there's trust, And the physician has to be willing to accept your phone calls when you call, when you do have questions. So setting that expectation is really important, because you can't have a successful APP practice in the surgical setting without having that support. So in summary, APPs can work on the hyperacute setting, the outpatient setting, and vascular neurology, cerebrovascular neurosurgery. The goal here is for all of us to be successful in our roles and to improve patient outcomes in the long run. Thank you.